All right, so most of, well, all your protocols should start with the parasternal long axis view. Okay. Um, I mean, it's probably the most convenient area to start your study. And remember, to get your parasternal long axis view, your transducer or the probe should be in the third or fourth intercostal space with the marker pointing towards the right shoulder. And you're going to get an image looking like this. So you have to imprint this in your brain. All right. So again, the chest wall is up there. Then you get to the RV wall. This is the RV outflow tract, RV cavity. This is the septum. The LV cavity is right inside there. Your posterior wall, below the posterior wall, you have your pericardium, and this is the descending aorta. Okay. The mitral valve is right here, the anterior leaflet of the mitral valve, posterior leaflet, the left atrium. Your aortic valve is right there. Okay. The aortic root, just a, just a, just beyond the valve. You can define the aortic root either from sinus to sinus or from or at the sinotubular junction. The correct, well, anyway, the correct root is usually at the lowermost portion of the sinus. And but anyway, for when you're doing your measurements from sinus to sinus or at the sinotubular junction, and it's very important to know how to do your measurements, where to do, because you're going to be tested on that. So this is the parasternal long axis. It's in play. You can see in systole the muscle thickens, and diastole it thins. Okay. All right. So see it in play. The anterior mitral leaflet, the posterior leaflet is right there. Okay. Aortic valve opening and closing. The aortic valve opens in systole, closing diastole. The mitral valve opens in diastole, closing systole. You have your ECG on the bottom. Okay. You always have your ECG on the bottom. Well, some system have it on top, but okay. All right. So let's look at. All right. So measurements. You have to be sure where you're doing your measurements. So you in systole you're going to do certain measurements, and in diastole you're going to do certain measurements. So you have to know the measurements that you're going to do in systole and the measurements you're going to do in diastole. So this is a systolic frame, because the mitral valve is closed, the aortic valve is open, and you usually put your marker at the peak of the T wave, okay? But you can check your image to make sure that you're at the correct position. So you're gonna do you can do your septal uh, thickening in systole, LV cavity size in systole, and the posterior wall in systole. In systole, you have to measure the left ventricular outflow tract, which is just a little bit in front of your aortic valve, about 3 millimeters. It's from the blood tissue plane to the blood tissue plane. So it should be from tissue to tissue. You're also going to measure the size of the left atrium. Okay, size of the left atrium. And remember, your measurement should be perpendicular to the walls. All right. So in diastole, when the mitral valve is open, the aortic valve is closed, you measure your septal thickening in diastole, the LV cavity size in diastole, and the posterior wall in diastole. Remember, your measurement should be at the tip of the mitral valve, You also should measure the aortic root in diastole, okay? That's a little bit controversial, but for exam purposes, it is measured in diastole, okay? Diastolic measurement. So you have to know what measurements you're going to do in diastole and what measurements you're going to do in systole. It's very important because you're going to be tested on it. All right. Okay, so again, your left atrium should be measured in systole. The aortic root should be measured in diastole. And your measurement should be from the what we call the leading edge to the leading edge. Okay, so from just outside of the wall to the first portion of the wall down there. So from leading edge to leading edge. That's the current recommendation. So know the measurements you're going to do in diastole and the measurements you're going to do in systole. So always remember to play. All right. So you have to know the structures: chest wall, RV, outflow tract, the septum, posterior wall, LV cavity, mitral valve, the anterior leaflet, posterior leaflet, the aortic valve going into the aorta. Okay. And if you see something that you need to measure, if the ascending aorta looks like it's dilated, you should measure it. Okay. So if you're going to measure the ascending aorta, you measure it. All right. So this is our RV inflow view. So remember, from your parasternal long axis, if you just tilt your transducer, you can get your RV inflow view. And you have to know the structures involved. So up top, you have the RV. At the bottom, you have your right atrium. Tricuspid valve is right there. You have the posterior leaflet, the anterior leaflet. You'll have where your inferior vena cava drains into the right atrium. Above that, you'll have the coronary sinus. And then the LV cavity will be over there. Okay. So remember, when you're doing actual studies, not all your studies are going to come out looking perfect. I mean, you have to have a protocol. Okay. So you need to develop a sequence in which you do your studies so you don't miss anything. So this is the short axis at the level of the aorta. Short axis at the level of the aorta. So your aortic valve is your aorta is right there with the aortic valve inside. Over here you have your tricuspid valve. You have your septal leaflet, the anterior leaflet. Up here This is the right ventricle flow tract. Sorry, this is the right ventricle inflow tract. Right ventricle flow tract is right over there. So right ventricle inflow tract, tricuspid valve. This is your right atrium. Your atrial septum is right there. Left atrium is right there. Okay, so let's play it. You can see the aortic valve opening and closing. So what, because you have to record the study. So what I recommend that you do is you can play around until you get a good image, but only record the good image, all right? Or the best image then, because sometimes it's not. So we don't want to see everything. The person who is reading the study don't want to see everything. So you can play around. When you get your good image, then you record that. So it says your aorta with the aortic valve inside, pulmonary valve is over there, tricuspid valve is right there. Okay. Okay. So if you look closely, you can see that your aortic valve, when it opens, you can see that there are three cusps. Okay. So you should try, when it's closed, you might see what looks like three cusps, but it's just a raphe. So you have to open the valve like this. Yeah, there's one cusp there, another cusp, and then the third one is right there. Okay. So again, up here you have the right ventricle up here. This is your right ventricle inflow tract and your right ventricle outflow tract. So the tricuspid valve is right there. This is the right atrium. Your atrial septum is right there. This is the left atrium. Remember the cusp, which is adjacent to the atrial septum, is the non-coronary cusp. Non-coronary cusp is right there. This is the right, and this is the left. Okay. So when a tricuspid aortic valve opens in systole, it has a triangular configuration. So I hope you can see that. See, it opens in a triangular configuration, okay, as opposed to a aortic valve which is bicuspid. When it opens in an American football configuration. It's an ovoid. Uh, so so you move on from the short axis at the level of the aorta. So you have to develop your own protocol. You might start at the apex and then go to the short axis at the level of the aorta, or you may start at the aorta and go to the apex. You have to develop your own protocol. So that is something that you do all the time. So if you're at the short axis at the level of the aorta, to get short axis, remember, from the position that your transducer is in to get your parasternal long axis view, you have to do clockwise rotation clockwise rotation of the probe, and to get the short axis at the level of the aorta, you have to tilt the probe downwards. So the top of the probe, you're going to tilt it downwards, and then you'll get short axis at the level of the aorta. To get short axis at the level of the base, you have to tilt it up a little bit. So at the base, that's where you have your mitral valve. So this is short axis at the level of the base. Okay, so this is the RV wall, and this is what we call this your bread loaf in the heart. So if you were to lay the heart down, okay, if you lay the heart down and you cut it, you do cuts along the surface of the heart, going all the way to the base. This is what you would see. So this is the myocardium. The myocardium. Remember, up top, this is the anterior wall. This is your inferior wall. Lateral wall is over here. This is the septum. But remember, we divide you get 6 segments from this view. So this would be your anterior lateral wall. This would be your inferior lateral wall. Over the septum, inferior septum, anterior septum. The RV is over here. Okay. And then the mitral valve is inside. So the anterior leaflet of the mitral valve is up there, and this is the posterior leaflet. So this is short axis at the base. You have the mitral valve inside, the anterior leaflet up top, and this is the posterior leaflet, LV cavity over there. So you're still at the base, and you're moving towards the papillary muscle. So where you have the papillary muscle, that's what we call the mid-cavitary level. So if you move from the aorta, short axis at the level of the aorta, you're gradually raising your transducer up. So you'll get to initially, if that's your protocol, that's how you're doing your study. So you're going to gradually move it up. So from the short axis level of the aorta, you'll get to the base where you have the mitral valve. Move it up a little bit more. Then you'll get to the mid-cavitary level where you have the papillary muscles. So this is still, well, they actually move from the base to the mid-cavitary level where you have the papillary muscles. But in the mid-cavitary level, you still have 6 segments. Remember, we do segments. So you still have 6 segments where this is the anterior wall, inferior wall, lateral wall, and then this is your septum. But you can divide the lateral wall, anterior lateral wall, and this is your inferior lateral wall. This is your septum, inferior septum, and your anterior septum. Papillary muscle, this is your anterior lateral papillary muscle, anterior lateral papillary muscle, and this is your posterior medial papillary muscle. Okay. So, all right, so you finish, and then you're supposed to get your apex. So in the short axis, if you start at the level of the aorta, you'll get your aorta in short axis. You'll get the base where you have the mitral valve. You get the mid-cavitary level where you get the papillary muscles. Then you go on to the apex. Remember, the apex, you have only 4 segments or 4 regional walls: anterior, inferior, lateral, and septum. So then you move on to your apical views. So to get your apical 4-chamber view, the transducer, the probe, is positioned, 4 or 5 o'clock position. So the probe is positioned at the apex. The probe is positioned at the apex, and the apex usually at the mid-clavicular line, the 5th intercostal space. The marker, 3, 4 o'clock position, or if the heart is enlarged, you have to palpate, find the apex, and put your probe there. Okay, because if you don't do that, you're going to foreshorten the image. So, but you're supposed to get something looking like this. Remember, you have to have a mental picture of the image. Okay, mental picture of the image. So you're gonna get something looking like that, and you can see in systole the walls move in, and diastole it moves out. Okay, systole the muscle thickens, diastole it thins. Okay, so this is your lateral wall. The apex is right up here. This is your septum. The mitral valve is right inside there. This is your LV cavity. LV cavity is right there. This is the anterior leaflet of the mitral valve and the posterior leaflet. Anterior leaflet of the mitral valve, posterior leaflet. This is your left atrium. Your pulmonary veins are down here. Okay. This is one on the right side that you can see right here. You're supposed to get 2 on the right side and 2 on the left, but you can only see 2 in this view. This is your right superior, and this is the left superior pulmonary veins. Remember, the pulmonary veins drain into the left atrium. This is your atrial septum. This is the right atrium. Tricuspid valve is right here. Okay, so this is the septal leaflet and the anterior leaflet of the tricuspid valve is right there. RV cavity. Okay. So if you just eyeball this image, you can see that the contractility is very decent. If you put something in the center, you see the walls almost coming and touching your pointer. So that is a normal LV systolic function. However, you're supposed to do measurements, okay? So remember what we said in diastole, you need to get ejection fraction. Okay, so you're gonna use your modified Simpson rule or your method of disc. And so in diastole is at the onset of the QRS, so your marker should be at the onset of the QRS, and you do planimetry of the wall. So you're gonna do planimetry of, so you just plane the LV cavity size in diastole, okay, and the computer will give you a volume, it will give you an area, okay, and then in systole, which is at the peak of the T wave, you do the same thing. So you do planimetry of the endocardial border in systole. Okay, you do planimetry of the endocardial border in systole, and the computer will give you the diastolic volume. It will give you the systolic volume, and what it does after that is to minus the systolic volume from the diastolic volume, put that over the diastolic volume, multiply it by 100, and you get an ejection fraction. So the computer will give you the ejection fraction. You don't have to do anything more than play. So the method is the modified Simpson rule or the biplane method of disk. Okay. Okay, so this is your 5-chamber view. So 5-chamber view, because you can see the aortic valve, the aortic root, and the ascending aorta. And in this view, you see the moderator band in the right ventricle. You see the moderator band. So from the apical 4-chamber view, if you tilt your transducer downwards, so remember these are finesse movements. It's not any abrupt and large movement. Very gentle. Tilt the transducer downward, you get the 5-chamber view with your aortic valve right there. So, and you can see the moderator band up there. Okay, apical 5-chamber view. This is the aortic valve, aortic root, ascending aorta. So this is your 2-chamber view. So you're in the apical 4-chamber view position. You're going to counterclockwise. You're just counterclock your transducer just a little bit. You know, to when you're doing your echo, once you start practicing, you start doing echoes, you just look at your screen. You know, you don't usually don't look at the patient to see what you're doing. You look at the screen and you know it's very fine movements, uh, delicate movements. So you know you will know once you get the image, you'll see it on the screen. So this is your apical 2-chamber view. The inferior wall is right there, and this is your anterior wall. Okay, inferior wall, anterior wall. Okay, so counterclock movement of your transducer. Your mitral valve is right there, LV cavity, left atrium. Okay, so your anterior leaflet of the mitral valve, the posterior leaflet. And remember, you divide the walls. You know, remember you have to know how to name your segments. So the mitral valve is right there. So this area close to the mitral valve is the basal area. So this would be your basal anterior wall. This would be your mid anterior wall, apical anterior wall. And then the inferior wall, this would be your apical inferior wall. This would be the mid and then the basal inferior wall. This is your apical 3-chamber view. So to get your apical three-chamber view, you're going to move the transducer more, you're going to turn it more counterclockwise, just a little bit more counterclockwise. And this is the image you're supposed to get. So it should be imprinted in your brain. So once you get that image, you just stop. So this is your, what we call the inferior lateral wall there. This is your anterior septal wall, your aortic valve, aortic root, ascending aorta. This is your left atrium, mitral valve is right there. Apical three-chamber view, because this is one chamber, second chamber, and this is the third chamber. So apical three-chamber view. Okay. Aortic valve opening and closing, mitral valve opening and closing, inferior lateral, anterior septal. So further counterclockwise rotation. So once you start scanning, you need to develop a sequence in which you do your scanning so that you can get everything in. All right. So if your protocol is to do two-dimensional, all your two-dimensional stuff, and then you're going to do Doppler, then so be it. Just make sure you don't miss anything out. So this individual's protocol was to do all the two-dimensional images and then go on to Doppler. Remember, your color flow Doppler is a form of pulse wave Doppler. Okay, your transducer is right there. Okay, this is a power sternal long axis view. If there is flow towards the transducer, it's going to be in shades of red. Flow away from the transducer is going to be in shades of blue. Okay, color flow Doppler. If you have very good eyes, you can see that there is a little jet which comes right there, and it has a sort of bluish uh, coloration to it. So if it's blue or bluish or any shades of blue, that means it's moving away from the transducer. Okay, so it will be going like this then, moving away from the transducer, not moving towards the transducer. So if this is our mitral valve is right here. This is our LV cavity. This is our left atrium. So that jet more than likely is mitral regurgitation because it suggests that there is flow from the left ventricle across the mitral valve into the left atrium. This is the jet I'm talking about. It's very tiny, so you don't expect it to be much. Color flow Doppler. It's a form of pulse wave Doppler. All right, so now this is color flow across your tricuspid valve. This is your RV inflow view, and you can see the same thing if you look closely. So you should look, you can look across walls and you can look across valves. The color flow will tell you if there's it tells you about flow. So if a flow is abnormal, you can see it. Remember that towards the transducer, it's gonna flow towards the transducer, it's gonna be in varying shades of red. Flow away from the transducer is gonna be in varying shades of blue. So this is varying shades of red. So that means there's something moving towards the transducer, which is the normal flow, because this is the right atrium right here, the right ventricle. So the normal flow from the right atrium to the right ventricle occurs in diastole across the tricuspid valve. So that's why you see that shade of red. But you'll see something if you look closely right across the tricuspid valve. You see shades of blue. It's a jet right here. Okay, so this is tricuspid regurgitation. It's shades of blue. It's moving away from the transducer. Transducer is right up here. Tricuspid valve is right there. So we get the shade of blue here. So it's moving away from the transducer. So it's moving from the right ventricle across the tricuspid valve into the right atrium. It's tricuspid regurgitation. Right there. All right, so those of you who see something right here, let's look at it. There's something right down here, right? So remember, you have the right atrium here, your inferior vena cava, okay, the inferior vena cava. So blood is flowing from the inferior vena cava into the right atrium. So it's not exactly moving up towards the transducer, but it's close. It's moving this direction, so that's why you get this sort of mosaic color. Okay, that suggests flow from the inferior vena cava into the right atrium. It's more shade of red. All right, so this is across. So this is short axis at the level of the aorta. The pulmonic valve is over there. This is your tricuspid valve on this side. So remember, you have to develop a routine, something that you do all the time, so you don't miss anything. Because if you don't, you're gonna miss a lot of stuff. All right. So the color is across the. You put the color across the pulmonic valve. Okay. So we know that blood flows from the right ventricular outflow tract across the pulmonic valve into the pulmonary trunk. So the blood is actually moving away from the transducer. So it should be in varying shades of blue because it's moving away from the transducer. Okay. But if you look closely, if you have very keen eye, you see that there's a little jet, if you want to call it red jet, a varying shades of red jet right there. So it is a flow towards the transducer. Okay, let's look again. If you look closer, there's a little reddish jet. So red is flow towards the transducer. So it suggests that there is a flow from the pulmonary trunk across the pulmonary valve into the right ventricular flow tract. So it's pulmonic insufficiency or pulmonary regurgitation. Okay, pulmonic insufficiency, pulmonary regurgitation. All right, so now we're over the tricuspid valve. Okay, so we see a number of things across the tricuspid valve. We see this, there's a red predominant, there's a lot of red. So that means there's a flow towards the transducer. The normal flow is from the right atrium across the tricuspid valve into the right ventricle. That's a normal flow. So that is why it's red, because it's flowing towards the transducer. Towards the transducer. We also see a flow right down here. So there's a flow right here. This is the right atrium. Okay, you have your inferior vena cava right there. Inferior vena cava is going to drain into the right atrium. So you see varying shades of red suggesting flow from the inferior vena cava into the right atrium. So your color flow, again, is a form of pulse wave Doppler. It gives you a quick recognition of flow and abnormal flow. So if there's something that's abnormal, you can pick it up right away and you can cone in and further evaluate what's going on. Okay, so a lot of individuals will do the color flow first to just pick up what's going on, and then you can do additional maneuvers to look at it. So apical four-chamber view, the color is across the mitral valve. Okay, so you have some red, and if you look closely across the mitral valve, there's this jet of blue right there. Just looks closely, it's a jet of blue right there. Okay, so blue, varying shades of blue means that the flow is away from the transducer. It's across the mitral valve. So we have flow from the left ventricle across the mitral valve into the left atrium. That's the definition of mitral regurgitation. So that's what mitral regurgitation looks like right there. And then this red is just a normal flow in diastole, okay? Because, I mean, flow is in diastole, blood flows from the left atrium across the mitral valve into the left ventricle. So that's a normal flow. Okay. So this is a 5-chamber view. Okay, 5-chamber view because you want to open the aortic valve. You want to look at flow across the aortic valve. So the 5-chamber view. Okay. So there's probably a lot of blue there. Your transducer is right there. It's the normal flow is from the left ventricle across the left ventricle flow tract, across the aortic valve into the aorta. So it's moving away from the transducer, so you should get blue. And you know, it's a 2-chamber view, you do the same thing. So you have to develop a routine and stick to that routine, okay? Because you have to evaluate your valves and structures in multiple views. Okay, so, and if you look closely, you can see that there's a jet, varying shades of blue, just below the mitral valve, which suggests that there is a flow moving away from the transducer. That means it's moving from the left ventricle across the mitral valve into the left atrium. Okay, so that's mitral regurgitation. And for the apical 3-chamber view, you do the same thing. All right, so have a protocol, stick to the protocol, you won't miss much. So, and if you look closely, you can see that blue jet across the mitral valve, suggesting mitral regurgitation. Or variant shade of blue jet. All right, so now we come to the other forms of Doppler. So this is C doubler, and you press the C doubler button, and there's some indication on your screen that will tell you you're in C doubler. So if you look, you see C doubler, continuous wave Doppler. So if you're looking for high velocity flow, you use your C doubler, high velocity flow. So your ECG is on the bottom, and you see, so these are artifacts right up there. But if you look here, there's a pattern. You have a flow below the baseline there. There's one there. There's another one there. Your transducer is across the tricuspid valve. This is your RV inflow view. RV inflow view. Your cursor is across the tricuspid valve. Your transducer is depicted right here as that. Okay, so you have this pattern below the baseline, so it suggests that there's a flow away from the transducer. So the flow is from the right ventricle across the tricuspid valve into the right atrium. This is tricuspid regurgitation. This is what it looks like. Okay, it's below the baseline because it's moving away from the transducer. Transducer is right there. So it's moving this way from the right ventricle across the tricuspid valve into the right atrium. It's below the baseline. C double because we expect a large velocity. Okay, velocity is on the vertical axis and time is on the horizontal axis. Okay. So this is so you're gonna remember, you evaluate if the patient have tricuspid regurgitation. Anywhere you have the tricuspid valve, you need to do Doppler study across that. Okay, so again, you have C doubler, and you have your ECGs on the bottom. Everything is gated in echo. You have this flow. There's one there. There's one there. Okay, it's below the baseline, suggesting that there's a flow which is moving. The transducer is right there. Flow is moving away from the transducer. Your cursor is across the tricuspid valve, so it suggests that there's a flow from the right ventricle across the tricuspid valve into the right atrium. It's below the baseline. Okay, tricuspid regurgitation. It's a systolic flow, which systole is from the onset of the QRS to the end of the T wave. It's a systolic flow below the baseline. Okay, C double for large velocity flow. Okay. Okay. Now we have, so short axis at the level of the aorta, and the cursor is across the pulmonic valve. Sample volume is right at the right ventricular flow track, and you get this pattern, okay? Your transducer is right there. It's below the baseline, suggesting that there's a flow moving in this direction. We know that the normal flow in the heart is from the right ventricular outflow tract across the pulmonic valve into the pulmonary trunk. It's moving away from the transducer, hence it's below the baseline. We know it's a systolic flow, so it's from the onset of the QRS to the end of the T wave. Systolic flow, pulmonary. You also have to know what velocity or what flow you're going to use PW, what flow you're going to use CW. That's you always get that on tests, so you have to know. So it's PW denoted right there. You have to know which flow you should use PW, which flow you should use CW. For low velocity flow, PW. Higher velocity flow, CW. Once the velocity is about 1.5 to 2 meters per second, you have to use CW. Okay, PW across the right ventricular flow tract. Okay, so there is right, there's nothing much here, but your transducers across the pulmonic valve. It's right in the right ventricular flow tract. ECGs there, and so you get this little blip. You know, we know that this is the forward flow. This is a systolic flow. It's below the baseline. We know it's a forward flow across the pulmonary valve. But in diastole, which is from the end of the T wave to QRS, in diastole you have this little thing here. So it's above the baseline. So therefore it's a flow towards the transducer across the pulmonic valves. This is pulmonic insufficiency, pulmonary regurgitation. It's a flow towards the transducer. Transducer is right there. So if it's flow towards the transducer, it's above the baseline. The only flow that can occur here towards the transducer is pulmonic insufficiency, pulmonary regurgitation. Remember, the normal flow is from the right ventricular flow tract across the pulmonary valve into the pulmonary trunk. All right. So this is our apical four-chamber view. Apical four-chamber view. Our cursor is right there. And at the tip of the mitral leaflet, this is our sample volume. Okay. This is our this denotes our probe or transducer. This denotes the probe or transducer. So we get a flow, we get flow above the baseline. ECG is on the bottom. This flow is a diastolic flow. Remember, diastole is from the end of the T wave to the QRS, end of the T wave, QRS. So we get this repeated diastolic flow, okay? And it's above the baseline. So it's telling us that there is a flow from the left atrium across the mitral valve into the left ventricle. It's moving towards the transducer, hence it's above the baseline. Flow from the left atrium going across the mitral valve into the left ventricle. It's above the baseline. So this is a normal diastolic flow, which, you know, blood flows from the left atrium across the mitral valve when it's open in diastole into the left ventricle. So that's what you're getting here. And remember, it's a low velocity flow, usually less than 1 meter per second, hence pulse wave Doppler. Pulse wave Doppler. This is our E velocity. Remember, when the mitral valve opens, there's a sudden rush of blood from the left atrium into the left ventricle. Then you have an equalization of the pressure, we call diastasis. Then the atrium contracts to give your A velocity. Okay, so these are relatively low velocity flow. So it's PW, E velocity, A velocity. This is your diastasis. Your IVRT is right there. So you have flow across the aortic valve closed. The mitral valve is also closed. This is your IVRT, isovolumic relaxation time. Then your valve opens, mitral valve opens, suction of blood from the left atrium into left ventricle, equalization of pressures. Then the atrium contracts, A velocity. Then the mitral valve close. The aortic valve is still closed, so you have your IVCT, isovolumic contraction time. PW. Okay, so you're still across the mitral valve, and you can see your sample volume or your point of interest is lower, so you're not at the tip. You get this, so you look at your Doppler, you get this pattern. There's a little thing there, there's a little thing there, there's a little thing there in systole. Okay, so systole is from the onset of the QRS to the T wave. So in systole, you get this little patterns below the baseline. You're across the mitral valve. Transducer or probe is right there. So it suggests that there is something flowing from the left ventricle across the mitral valve into the left atrium. So this is mitral regurgitation. Very tiny, very tiny, but it suggests mitral regurgitation. Okay, so this is supposed to be a pulmonic flow, but it's not very clear, and we'll come across much better pulmonary flow in the future. But again, you need to develop a protocol. Okay. So you have to know what flow you're going to use PW, what flow you're going to use CW, high velocity flow. If you're going to assess something across, say, if you're looking for, say, a stenotic valve or a regurgitation, those are large flows, so you need CW. So again, so your two-dimensional echo is on top. We're over the right side. We're actually over the tricuspid valve. Transducer is right there. This is your cursor, sample volume or point of interest. And we get this little thing below the baseline. Okay, it is consistent. It's a systolic flow from the onset of the QRS to the T wave, systolic flow below the baseline. So it suggests that you have a flow from the RV, from the right ventricle, across the tricuspid valve into the right atrium. So it will be tricuspid regurgitation. Okay. All right. Now this is across the left ventricular flow tract. Remember, this is your two-dimensional echo, 5-chamber view. The cursor is right there. Sample volume is across the left ventricular outflow tract, transducer or probe, and you get this systolic flow. It's a PW measurement. So this is the flow across the left ventricular outflow tract, flow from the left ventricle across the left ventricular flow tract going towards the aortic valve. So it's moving away from the transducer, and it's below the baseline. It's a systolic flow. Your ECG is on the bottom. Systole is from the onset of the QRS to the end of the T wave. It's a systolic flow below the baseline. So this is flow across the left ventricular outflow tract. Okay, 5-chamber view. Okay, again, so this is across the aortic valve though. So you move a little bit lower. So you move from the left ventricular flow tract into the aortic valve itself. And we usually do C doubler because if you have something like aortic stenosis, you need to have a Doppler evaluation of a large velocity flow. So once you move into the aortic valve, you should switch to C doubler. Okay, it's a systolic flow below the baseline because it's flow across the aortic valve. So you have to evaluate flow across the left ventricular flow tract, which is pulse wave Doppler, and then flow across the aortic valve, which is continuous wave Doppler. Okay, this is a form of a tissue Doppler. As a matter of fact, this is not really a Doppler. This is a M mode measurement. You have not done M mode, but I can still mention it. Okay, so your two-dimensional echo is on top right here. Two-dimensional echo. Your tricuspid valve is right there. Tricuspid annular plane is right there. We actually put our cursor across the lateral tricuspid annular plane, and then we click the M mode button. And basically, what we're seeing here is the lateral tricuspid annular plane moving upwards in systole. So in systole, from onset of QRS T wave, this tricuspid annular plane moves upwards, and we can measure that, and it gives us an assessment of the RV systolic function. Well, some of you guys have not done that yet, but we can evaluate RV systolic function by doing that. And when we do right heart, then that will be one of the things we discuss. All right, so this is tissue Doppler. So this is so important. This is very important because remember, our next topic is going to be the evaluation of diastolic function and dysfunction. So this is the root of assessing diastolic function. Your two-dimensional echo is on top. Okay, your cursor is right here. This is your mitral valve is right inside there. This is what we call your medial mitral annular plane, and this is the lateral mitral annular plane. You put your sample volume at the medial mitral annular plane, and what you're doing, you want to see the velocity of that plane. You're looking at the velocity of that plane. Okay? So when you press so again, tissue Doppler is a form of pulse wave Doppler. It actually, because the tissue is moving at a much slower speed than the blood, we often talk about centimeters per second as opposed to meters per second. The tissue is moving much slower than the blood. So it's in the order of centimeters per second. And if you analyze what's happening here, your transducer, so it's Doppler, it's the same principle, nothing different. Your transducer is right here. Your sample volume is right there. So in systole, that medial mitral annular plane moves up because it's above the baseline. So in systole, it moves up. In diastole, it moves down, but you have an early diastolic wave and a late diastolic wave. So this is what we call S prime. Okay, it suggests the mitral annular plane moving upwards in systole and the mitral annular plane moving downwards in diastole. You have an early diastolic wave and a late diastolic wave. The early diastolic wave is what we call E prime. This is E prime and this is A prime. So, or S prime, E prime, A prime. Tissue Doppler imaging. Very important. Well, you can't assess diastolic function and dysfunction unless you do that. So if you look closely, we're now over the lateral mitral annular plane and you press your tissue Doppler imaging button, you get the same thing. You get your S prime, your E prime, and your A prime. Remember, S prime is a systolic phenomenon where the lateral annulus moves up towards the transducer and it's above the baseline. In diastole, it moves away from the transducer, it's below the baseline. Very important, it's present on all exams. The lateral E prime is usually larger than the medial E prime. You get this on all tests that you do. The lateral E prime is usually larger than the medial E prime. Okay. All right. And then we do volumes. You guys have not reached here yet, but so we're not going to really discuss how you do volumes. Well, yeah, we should. All right. So the current recommendation to look at the size of the left atrium is to do left atrial volumes. Okay, you know, we're moving away from linear measurements and doing volumes. So when you're doing left atrial volume, one of the methods that's recommended is the area length method. We also do the biplane method of disc as well to evaluate left atrial volume. And you do it in your 4-chamber view and your 2-chamber view. So what you do in the 4-chamber view, so you're gonna plane the left atrium. In the 2-chamber view, you do the same thing. You do planimetry of the left atrium. Okay. Okay, so when you plane the left atrial area in the 4 and the 2, you see that they're different. They're not the same. Okay. So what the computer does, or if you have to do it yourself, you take the area of the 4, you multiply it by the area of the 2, and you're going to divide it by the shortest length. So this is one length. This is the length in the 4-chamber view. This is the length in the 2-chamber view. And then you multiply it by 0.85, and it will give you the left atrial volume. But you have to index the left atrial volume. Left atrial volume that you're going to see, and you're going to use it to determine whether you have left atrial enlargement, yes or no. It's an index number. When we say index, you divide it by the body surface area. So if you just think about it a little bit, if you use the area So you're going to use the area in the 4. So let's call that area 2. So that's area 2. And we're going to, all right, area 2. And you're going to multiply it by the area you get in your 2-chamber view, call that area 1. And remember what we say, you divide it by the shortest length. So you're going to measure this length, you're going to measure that length. So the shortest length, call that L1. Okay, so remember, area is a distance square, so you are a length square, so you'd get a length to the power 4, and if you divide by just a length, your eventual you're going to get a length cube. A length cube is a volume, right? So, and you multiply this by 0.85. So don't forget that. So you're going to multiply all of this by 0.85. Okay, so you do your area in the 4-chamber view, area in the 2-chamber view. You get the length of each of them. So the formula is the area in the 4 times the area in the 2 divided by the shortest length, and you're going to multiply by 0.85. But to show you that the unit is consistent, area is length square. So when you multiply area by area, you get a length to the 4th power, and you divide it by a length, you get a length cube, which is a volume. All right. So the current recommendation is to, all right, and this is your subcostal view. So the liver is over here, okay? The inferior vena cava is someplace right there, and you can see this blue color right there. There's a blue, okay? Transducer is there. It's the blood is flowing into the right atrium. It's moving away from the transducer, and it's blue, or shades of blue. Okay, so you can see, you can put your color there. You see inferior vena cava. Inferior vena cava right there. The hepatic vein is going to drain into the inferior vena cava, so all that fluid is going to be blue. Right side of the heart is right here. The right atrium is right there. This is the liver. Hepatic vein is right up there. Inferior vena cava is right there. So again, this is a subcostal view. Inferior vena cava right there. And you have to do this view, because in order to give an estimate of right ventricular systolic pressure, pulmonary arterial systolic pressure, you have to measure the IVC, inferior vena cava. So you have to do your subcostal view. Again, subcostal view, right ventricle, right atrium. Excellent view to look at the ventricular septum, atrial septum. If you're going to measure the thickness of the RV wall, if you're looking for pericardial effusion, Excellent view. Okay. So, not sure what they're trying to do there. All right. So this is actually your, I think this is your supersternal notch view. Let's see. All right. Yeah, this is your supersternal notch view. So, of course, you position your transducer in the supersternal notch, and you can either look at the ascending aorta, the arch, or the descending aorta. This is actually in the descending aorta. So the transducer is right there, descending aorta. Blood is flowing away from the transducer, so it's below the baseline. Okay, systolic flow. It's a PW measurement. However, if you see evidence of obstruction, because you're going to put your color in first, and if you see turbulence, you put your PW. If you see aliasing, then you switch to CW and look at it. Because if you have coarctation of the aorta, that's where you're going to find it. Supersternal notch view. Okay. All right. So this concludes looking at basic